Welcome to the second session of the program. I can see even Dr. Pradeep has joined.
Good morning. Oh, sorry. Good evening, ma'am. Good evening to all.
Very good evening. Very good evening. Yeah. So we have Dr. Pradeep also with us today because he couldn't join the last class. So now we are all there. We all are. The chorus is complete, I can see. So as I said that taking that understanding that effective communication is important. The second session is all about how to go about doing it. We all normally think that I communicate effectively. I think I know how to speak, I know how to behave, and we assume that communication happens effectively. But I think this session will open our mind to the idea that sometimes not communicating is also a communication. And sometimes when we think I have communicated, it could actually go very, very wrong. So we are going to understand the finer details of communication. I'll be starting with two videos. So although the video is a depiction of interaction between the patient and a doctor, but you could take yourself in that place as some of your quality personnel. So if you're not directly interacting with the patient, but you're interacting with your fellow professionals, doctors, nurses, paramedical staff, or if you are if you are a clinician, then of course you are handling patients. So it will give us an idea about the finer nitty-gritties of communication, which sometimes we miss. This session particularly will help you not only to work on yourself, to be more mindful of your communication and behavior and finer details, but also when you will start helping people learn how to communicate effectively, this session will come handy. So that's the purpose I have kept this session as the second topic. So I'll be showing you two videos. As I said, it is the interaction between the doctor and the patient. Again, what you will see in the video, not that all of us exactly behave in the same manner, but then there are some things that knowingly or unknowingly we do. So the first video is normally what we see, and the second video is, would it have been in this one? So let me show you the video and then we take the discussion. Is my screen visible to all?
Okay. Yes.
What? Doctor, my leg is swollen and painful. Since when? For the last 5-6 days. What were you doing? Why did you wait so long? This looks pretty bad. Doctor, I thought the pain was just a strain in the leg. Anyway, what do you think now? You could have waited for some more time and we could have amputated your leg. Leave it. What's your sugar level? It is under control, doctor. The fasting was 140. When was it done? What was your HbA1c? It was 4-5 months ago. Actually, HbA1c is an expensive test and I was feeling all right. I can't understand. You do investigation according to your will. You don't take proper treatment. You don't follow our advice. I don't know why you need doctors. And you come up with all sorts of complications like this. And what did you do with your leg? I went on a pilgrimage to Sabrimala, so had to walk barefoot. I might have injured, I think. Barefoot? Hello? Yeah. Who? The patient Ram, HIV positive patient. So he doesn't want CT scan. So tell him if he wants treatment, he needs to undergo CT scan. Right? What does he think of himself, yeah? Prime Minister or President? See, discharge him against medical advice and tell him not to come to this hospital once again. Okay? Yeah, bye. And you got this boon. I'll tell you, if you go once again, you will also go near the God. Didn't I tell you about the foot care when you came last time? Huh? And your smoking is continuing without interruption, I guess. I've reduced a lot, doctor. I am smoking only 1 or 2 cigarettes a day now. Can't understand your attitude here. You do smoking, you are overwhelmed, you don't take medications, you don't do investigations. I don't know what to tell you. I'm trying, doctor. And if you don't want to see me, I could consult someone else. See, whatever I'm telling is for your good. I don't know how to tell. I gave you information leaflets last time and you're not following my advice. And if you don't want to see me, it's fine with me. I have got enough work to do. I've got enough patients to see. Sister, please call the next patient.
Okay. So what did you notice in the video?
Right?
So,
Ma'am, actually, there was no greeting, at least we can, we must develop a practice of wishing our patient. And there is no introduction on the part of the doctor, and he isn't remembered. At least he can see the.
hold on. Sorry, I should have informed everyone. 1 person, 1 point. I want everyone.
Okay.
Thank you. You
Okay.
brought in a good point that he did not greet. I completely agree. Usually patients greet. We can respond. है ना? Patient कहते हैं नमस्ते. हम नमस्ते का जवाब. नहीं patient बोलता, हम नमस्ते बोल सकते हैं. But then he did not greet. I completely agree. Okay. Anybody else? 1 point, 1 person. Yes, we do.
Yeah.
And then
He was interrupting when the patient was about to tell his complaints fully or
Okay.
symptoms. He was interrupting.
He was
He was not ready
distracted.
to
Okay.
listen.
He was not interested. He was distracted. Yes, Mitu, go ahead.
There was no eye contact with the
No eye
patient.
contact. Absolutely. Especially when the patient comes in and you don't make eye contact, patient does not know whether you really know who I am and why am I here. Do I exist for you? Do I exist for you? Okay. Arshia, what do you say? What did you observe?
I think it was a very paternalistic conversation that the doctor was having. He was intimidating the patient.
Absolutely. Very nice, very, very deep, interpretation that you have given, that he was more like a authoritative and aggressive father, or a paternalistic approach that you're talking about. I think very clearly visible. Absolutely. Michelle, what do you say?
So I was thinking, even though he's the patient who's already somebody who's known to him because he's come here before, there was no kind of follow-up in terms of what was there before to what is now. And
Absolutely.
it seemed like he was a stranger there.
Wonderful.
So
Wonderful.
no, kind of interaction or rapport, any of it.
Absolutely. So the whole quality of interaction was just not gratifying to anybody. Absolutely. Shikha, what is your observation?
Ma'am, all the points are covered, I think.
There are a lot of points. There
He
are
is
10
not
more
a good
points.
listener.
10 more. He was not a good listener. Absolutely. He was not a good listener. How about,
Privacy.
sorry. Oh, yes.
Privacy. He talked
Yes.
about the another patient in front of him and talked about the confidentiality of the
Absolutely.
reports was also not into it.
He named the patient and then he talked about his HIV.
Privacy.
Privacy was confidentiality and privacy both were completely not looked after. And also the way he was talking about the patient,
Rude
patient would
behavior.
think, patient would think that in my absence, does he talk in the same manner? What does he think of himself? Is he a prime minister of the country? Anything else?
Yeah, I had one more about
Michelle, hold on, Michelle.
yeah.
Yeah, go ahead. Yeah.
So I had one more about how that dynamic in the sense the both of them, their interaction, and how at the end, right, it ended so abruptly.
You don't
Like, he
care
got
for me.
angry and he said, I have other stuff to do, so
I have a lot of work.
you're not my problem really. So
Absolutely. Yes, me too. At a point,
So
yes.
the other was about his patient right. So he has a right to go for a second opinion, which he was like,
He was very upset. Jana hai to jao, I don't care. I don't care. And what else? He made mockery of patients' religious beliefs.
Speaking without
Religious
interruption, and
There is a
those-
possibility that you probably thought that I'll go barefooted for if this particular wish is fulfilled. I can explain to my patient that, see, for you, going barefoot or walking barefoot is not advisable because you're high diabetic. There's a risk of diabetic foot. All that is okay. But I cannot use threat as, controlling the patient. We'll have to amputate your foot. I can explain to the patient, see, you can't take risk by walking barefoot because you are high diabetic. There's a possibility of diabetic foot. And then in case if some infection happens, it will be very difficult to control. And there are high chances when patients have, this kind of, infection, it can lead to necrosis. And then there are cases where we had to amputate the foot. The whole thing could have been said in a more scientific and a professional manner. But look at the way he tried to threaten the patient. You will have to amputate your foot. Good that what? And what else? What else? Some
I
more
think
points.
there was lack of empathy, like that. There was lack of empathy.
Excellent. Very good point, Arshia. HbA1c may be a very cheap test for us, but for a patient who is probably maybe earning 500 rupees a day, for him paying for one test 500 rupees could be very, very expensive. So, that was complete lack of empathy. Absolutely. What else?
didn't give him any credit for his honesty.
Yes. See, people who drink and smoke, for them to actually even reduce smoking and alcoholism is very difficult. They need lot of encouragement and lot of support and lot of, so that they stay motivated and they come out of it. But if you talk like this, or it's not your cup of tea, you will not be able to do, you will never be able to come out of it. That really demotivates the person. Aapke bas ka nahi. He said, I've left cigarette, I'm smoking only one or two. A person who is smoking one pack, and if he's able to come to one or two cigarettes, it's a very big achievement. But if you are talking like this, you are not motivating, but you are cursing the patient. Any point that we have missed that somebody wants to add?
Bad body language.
Absolutely. I think that was one thing I was looking for. Look at the stiffness of his neck. Look at the expressions. Look at the expression: rude, aggressive, intimidating, no friendly, no smile, no welcoming. The first question he asked, what was that? Can you recollect? What? और अगर मैं हिंदी में बोलूं, क्या है? Why are you here? Instead, if I say, हाँ जी बताइए, किस लिए आना होगा? But the whole intention and the meaning would be very different when you fail to use the right word and right tone of voice. Let's see the second video. And luckily, see, we have this set of videos done by Indian doctors. They are doctors actually from the Bangalore Baptist Hospital. They've really done a wonderful job. Though they are not actors, but they have done excellent acting, to showcase how we fail. Now, you see, this behavior we see very often among our healthcare professionals. I won't say only doctors. Even on front desk, people don't make eye contact. People don't smile. They are not forthcoming. They are not ready to listen. They don't pay attention. They are not listening. They are doing something else. They are multitasking. He was looking at the file. Maybe it was patient's file. But how does the patient know that it is my file that you are looking at? And that's what we do when the patient comes to lab or radiology or pharmacy. We are busy doing our work. We don't look at the patient. We don't say, हाँ जी sir, बताइए क्या काम है? How can I help you? We just do not use those basic courtesies that we are expected. Now let's look at the second video. could the whole conversation be like this? And it would have really led to a lot of satisfaction, both for the doctor and for the patient. Let me show you the second video.
Next. Hello, Mr. Kannan. How are you? Please take your seat. Thank you. What can I do for you?
Doctor, I think I have a problem with my leg.
What happened?
4 5 days back, I went to Sabrimala and I had to walk barefoot for some distance.
Mhm.
I'm very scared now because my leg is swollen and painful in the last 4 5 days, and I think I did a stupid thing by walking barefoot.
Let's see what we can do. Good that you realize the importance of foot care. Meanwhile, how are your sugars?
Actually, my fasting sugars was 140, but it was some months ago. I was feeling all right and I didn't do the HbA1c. It is so expensive, you know.
It is expensive indeed, but it is so important to get the investigations prescribed by the doctors because otherwise it's very difficult to give the treatment, and treatment may not work as well. Anyway, can I examine your leg?
Yeah, sure. Sorry, sir, it was my mistake. I didn't do the test.
Hello? Yeah? Yeah. Excuse me for a moment. Yeah. What's the name of the patient? So he doesn't want the CT scan, right? Yeah. Try to explain to him the importance of CT scan. Yeah. When I come for rounds, I will also tell him. Okay. Thanks for informing. Thanks. Bye. Sorry about that. You got infection in your leg. So how are we doing regarding the quitting the smoking?
Regarding smoking, it's doing good. Actually, I brought it down to only 1 or 2 cigarettes per day now, doctor.
That's good. But total quitting is very important. See, if you have reduced from 1 pack to 1 or 2 cigarettes per day, quitting that is also not very difficult, And how are we doing regarding the exercise?
Yeah, going on, but I must admit, not so regular.
See, exercise and diet are as important as your medicines, if not more. But for the time being, you need admission for sugar control and control of this infection. Is it okay with you?
Whatever you say, doctor, you have to cure me this time, and hereafter I will definitely take care of myself. This will not happen again.
Yeah. We need to control your sugars and control the infection. Otherwise, it may go for gangrene and may lead to further complications. Now, the sister will go through the procedure and admission process. Okay. And meanwhile, you have this leaflet and you can go through it, which will help you to follow the regimes. Okay. Thank you very much.
Thank you so much, doctor. It was so kind of you.
You're welcome. Thank you.
So, is it very difficult to actually practice? But do we practice this? And again, it's not just between the doctor and the patient. All of us who are handling patients, their family members, our fellow professionals. Are we practicing this? And if you look at the length of the video, this video was shorter than the previous one. Because when you talk to the point, you talk less. You use less energy. And at the end of the discussion or conversation or consultation, both parties should go happy and satisfied. But that can only happen if we really know how to behave in a professional manner. Okay. So taking this further, any idea what percentage of our personal and professional success comes from our communication and interpersonal skills? Any guess?
50%.
60%.
Okay, 60%. Any other guess?
80%.
So Maheshwari, is it a guess or you knew it?
It's a guess.
It's a guess.
Not guess.
Just understand.
It depends on the, yeah, like by understood by my conversation with the people or anyone.
Absolutely. So this is the only class where you can give all wrong answers. You are free to give wrong answers. Only thing is you have to answer. You have to try. You have to, speak up. You're very close to the answer. Actually, a study by Harvard has revealed that 85% of our personal and professional success comes from our communication and interpersonal skills. Imagine. We pay so much of attention to the clinical skills and technical skills, but your happiness, your contentment, your professional success, your personal success is majorly dependent on your ability to communicate and network and behave and know what are the rules of the social game. If you try to recollect your friends in your college time, and if you try to, if you were all in the same class, you came out with the same qualification. But if you now try to see where they are, people who really had good communication and interpersonal skills, they must have been at much better position than anybody else. Not that you don't have to work or you have to just please people and be happy, but no. If you know how to take people with you, see, there was a time where IQ was valued very highly. So people were valued if they were out from a very prestigious institutions. Oh, he's from IIM. Oh, he's from AIMS. He's from a particular medical college or a particular institution. But then when it came to practically working with people, people with very high IQ sometimes just miserably failed in connecting with people. And we see this happening across every subject. Then came the idea, which studies proved that people with higher EQ are more successful. This is again a study by Harvard that I'm sharing with you, that they when they went into finding out the satisfaction and happiness and success of people, alumni of Harvard, they found that people with average scores from Harvard, but high EQ were far more happy, satisfied, and successful. So this session will help us learn how do I cultivate this culture? First of all, how do I acquire these skills? Then how do I cultivate that culture at home? In how many ways do we communicate? Any idea? In how many ways do we?
Without
So through eye
without even
contact,
speaking, we can
verbal.
without
eye-
even non-verbal communication also happens.
Non-verbal communication.
language.
Absolutely. So if I may say, primarily we communicate in three ways, three modes. One is verbal, and second one is non-verbal.
No.
But non-verbal has two further categories. One is
Right.
paralanguage, which includes tone of voice, quality of your voice, speed, volume, pitch, intonation. And third is body language. So three broad ways that we use to communicate. One is language, second is paralanguage, and third is body language. What is the percentage of each in terms of their impact on the communication? Guess once again.
Non-verbal is
Body
the
language
least.
plays the major role. I mean, more of percentage.
Absolutely. Just guess. What do others say? What's your guess? What
Paralanguage
Body
is the
language.
highest. About
Body language, then voice, then verbal.
So what percentage of communication happens through body language?
I think around 10%.
What do others say? Okay?
Body language is 50% because first anyone will see you, how you are sitting, how you are interacting. Then it comes to paralanguage and then it comes to the verbal. Because it once you see the face of any person, you feel whether he's positive or a negative. So I think for
55% of the communication happens through your body language. 38% is your tone of voice. And 7% is language that we use. So, although we focus so much on language, but when your body language is not congruent with your words, and your tone of voice is absolutely not, communicating what you want to communicate, the message goes haywire. Somebody comes in and I say, "Aye." Somebody comes in and I say, "Aye." I didn't change the word, but I just changed the tone of voice. The whole meaning completely changed. So let's understand all three deeply. How do we be careful with all three? So are words important? Are words important?
yes.
Yes, they are important. And especially when the words are used at a place when they are not required. So let's do an activity to understand what exactly I mean to say when I say words are important, and we need to be very careful when we are picking words to communicate something. So let's assume that all of us are going for a picnic. We are planning, we are discussing, and every time you will start conversation, for example, each one of you will have to speak for one time. Every time you will start, you will have to say, "I'm okay with the plan of picnic, but." So usually after "but," what comes? When I say I'm okay with the plan of picnic, but what exactly do you think I'm going to say after "but"?
But if we can plan for the next week.
That means there is some objection or there is something that I'm not okay with. Okay. So I'm going to start the conversation, and I'll pass the baton to one of you, and then you can go on. So, okay, I'm okay with the plan of picnic, but I have some guests coming home this Sunday, so I wouldn't be able to make it. Me too.
I have to say the same thing. Okay.
Some but. That's your but, not my but.
I'm okay with the plan of picnic, but I would love to have all of you together.
See, after but it is usually some objection. Please remember. See, normally we say no, but ये कैसे होगा? But ये तो हो ही नहीं सकता. So with that idea, you have to, yeah.
So I'm okay with the plan of picnic, but I think I need to go to my son's school next week.
Okay, Michelle.
I'm okay with the plan of picnic, but I think you should have only non-vegetarian food.
Only non-vegetarian. Oh, I'm pure vegetarian. Okay, Ashya.
I'm okay with the plan of picnic, but I don't think this is a good weather to go.
Oh, yes, that's right. Maheshwari.
I'm okay with the plan of picnic, but I prefer on weekends, not weekdays.
Okay, Shikha.
I'm okay with the plan, but it must be near to my place.
Oh, but I live very far from your place. How do I reach your place? Okay, Dr. Pradeep.
I'm okay with the plan of picnic, but can we go next month?
Oh. Do you think with this discussion we will be able to go anywhere?
No.
Impossible. Okay, so I'm going to change just one word and you see how the whole thing changes. I'm going to replace this word but with and. So instead of but, now we will say and. I start the discussion. I'm okay with the plan of picnic and I will arrange food for all of you. Me too.
I'm okay with the plan of picnic and I'll arrange the logistics part.
You will arrange?
Logistics.
Logistics. Okay, thank you. You are a quality person. Thank you. You will do it in an excellent manner. Thank you. Yes, Michelle.
I'm happy to plan this picnic and have all of you agree to a common date. If all of you agree.
What have you decided?
If all of us agree to a common date.
The common date, yes.
Yeah.
So, and you're okay with that? If we all agree, okay. Arshia,
I'm okay with the plan of picnic, and let's take umbrellas because the weather is not too good.
oh, you're very caring, very nice. Thank you for reminding us, Arshia. That's very nice. Maheshwari,
I'm okay with the plan, but I want everybody
Oh,
to
but-
come in my car.
and I will arrange for transport.
Yeah, and I'll arrange the transport.
Excellent, wonderful. Thank you. And then Shikha.
I'm okay with the plan and I'm happy that everyone is coming.
Oh, very nice. Dr. Pradeep.
I'm okay with the plan of picnic, and we'll go next month and have fun together.
Wonderful. Excellent. Tell me what happened in the
Second
second round.
one is
Positive.
all positive.
A positive note.
Yeah.
The whole energy changed.
Felt more inclusive.
A lot of time we are in habit of using if and but at place where it is not even required. Especially when we are talking to people over whom we think I have authority, or I know more, or I will decide. So there we have a tendency to use lot of if and but. When you use lot of if and but, conversation cannot happen. Things will not grow. Things will not move. We need to be mindful of the fact that what is my language with people? Can you think of some words that you use often with your staff, especially with your subordinates, your junior, or with somebody whom you think I can say and they can't harm me in any way? Can you think of something that you have heard people saying or you have been doing with your junior or with your people?
Yes, I agree with you.
No, I'm talking about the
word.
wrong language. If I say I'm agree with you, then
Other way around.
I'm trying to help you to identify some words that we use which are not helpful, which are not going to, help us work together. Yes, sir. Go ahead. Dr. Pradeep, I think you wish to.
There are one or two consultants who used to say, "Are you mad?"
Ah,
When their junior says something, they suggest, or they are not able to do the work what they are supposed to do.
imagine in front of patients or with
In
other
front, everyone.
If you tell somebody like this, imagine that person's self-confidence. I mean, if somebody says you openly in public place, are you mad? कहाँ से मिली ये डिग्री तुम्हें? किसने दे दी डिग्री तुम्हें? कौन से कॉलेज से हो? कुछ सीखा भी है कि नहीं सीखा? चने बेचकर डिग्री ली है क्या? I've seen the people saying this. Patient को भी snub sometimes. भैया तुम इलाज कराने आए हो या मेरी नॉलेज चेक करने आए हो? इतने सवाल कर रहे हो. I'm sure you must have heard something like this. So we all, I'm sure we do use such kind of language with our even closed ones, even at home with our family members. We need to be more mindful of our. Somebody else who would like to share their? Yes, Michelle, go ahead.
I think labeling patients, saying that, oh, that irritating patient in that ward, or referring to them as their site of cancer.
Absolutely.
Also, I've noticed when somebody gives me feedback about somebody in my team, it's usually like a very elaborate, dramatic kind of thing. And I have noticed other colleagues would be like, pick up the phone and call them up right now. And I would be like, no, just hold on. So that also, I think, is something which I feel
Labeling the patient is very common. Michelle, I think very nice you have brought up. We say वो जो बहुत सनकी है, वो जो बहुत सड़ियल है ना? This is how we label them. Absolutely. I think that's again failure of language. So we need to be more careful. A lot of time when we are in authority position, when we know we can, bulldoze people, we are disrespectful. Many of you must have heard your seniors saying you, "Tu kar le, tu karti kyun nahi, tu karta kyun nahi." And in today's time, if you use this word "tu" or "tu" with your children also, they'll say, "Aap kaise baat kar rahe ho?" They won't like you saying "tu." They want to be called "aap." So I've seen, consultants, or seniors. It's okay when you have that kind of rapport with your team. I know when senior resident talks like this with their junior resident, after they have become very friendly and they are, they understand each other's intention, there it is all right. But when you are beginning with your relationship and you start using this language, people don't find it, respectful. Then a lot of time we also use authoritative and rude language. We are uncourteous. So in that video that we saw, he did not, when he picked the call, he received the call, he did not say to the patient that "I'm sorry, I need to take this call." But my question to all of us is, do we say sorry to the patient that "I'm sorry, I have to take this call"? You will have to wait. And in case if the patient receives call in our room, how do we react?
अंदर कैसे आ गए?
इससे बंद क्यों नहीं किया? लिखा है ना बाहर।
फोन को आपको पता नहीं है कि फोन बंद करना
बाहर लिखा है।
We shout at them. So you can well imagine that we don't use even basic courtesies when we are interacting with the patient. Not that we don't know, we know, but there we know we can throw our weight, we can behave the way we. So I think it's time that we understand that language plays a role. We need to be mindful of words that we use, especially with people who cannot probably give us back, especially if the patient is uneducated or poor. They would normally not say, "You are baat kaise kar rahe ho?" But they'll feel bad, they'll be hurt, and they'll carry that hurt with them. Now, coming to the tone of voice, if I may say, as I said, 38% of the communication happens through our tone of voice. And that is part of paralanguage. Your pitch, your volume, the rate with what we speak, the quality of voice, all that plays a very big role. So like I said, somebody comes in and I say, "Aye," and somebody comes in and I say, "Aye," the whole meaning changes. So I'm going to show you one slide and I want you to read that slide and you see how the whole intention of the message changes with just little emphasis on the word that I have underlined. Let me share the screen and show you. I've written one sentence 6 times. And if you read with little emphasis on the word that I have underlined, you will see the whole meaning changes completely. Could you notice? So as I said earlier, that 38% of the communication happens through your tone of voice. And mostly the conflicts are not because of the wrong words. It is usually because of the wrong tone. So we have to be careful when we are in a public place to make sure that we use appropriate tone of voice. So what do you think is inappropriate tone of voice? What all will come in inappropriate tone of voice?
High pitch.
Tone, our pitch doesn't matches with the conversation. Unnecessary up and down of pitch.
Okay, that could be inappropriate. Okay. Dr. Pradeep, you were saying something. Go ahead, please.
Ma'am, the same high pitch.
Absolutely. High pitch, high tone. See, this itself can trigger aggressive reaction. In a public place, especially, see, if the patient is misbehaving, but if your tone of voice, your selection of words, your body language is appropriate, people will see that you are acting very mature, very well behaved. The patient is misbehaving. But if the patient is misbehaving and if you are also behaving in the same manner, rather than pointing towards the fault of the patient, they will point a finger towards your behavior. So it's very important to remember that your tone of voice, if it is high pitch, high tone, it can trigger aggressive reaction. But in general, I think our tone of voice is unfriendly. I think you'll agree with me. We are not friendly. We think if I'll become friendly, probably the patient will come try to take advantage of it. But when we are not friendly, they feel that we are not connecting with them. So they feel disconnected with us. Also, a lot of time when they ask us something, and if the way we respond, we appear disinterested or we appear unconcerned. For example, if somebody is asking me something and I say, I'll find out, or let me think, but I'm not responding responsibly. Or somebody comes and tell me the patient has pain or is bleeding or has high fever, and my tone of voice does not indicate that I'm concerned. They feel that we are not affected, we don't care for them. At the same time, if somebody appears inconfident, that also is inappropriate, especially when they expect some amount of knowledge and experience and expertise that is depicted in our confidence. When we are replying to them, and if we appear inconfident, they will lose confidence. And then, of course, rude and authoritative. That's not appropriate in a public place, especially with patients and their family. And also, if you are aggressive, not a very right way of handling communication. The right way of communicating would be where you are professional but friendly. When you respond to situations in a responsible manner, if they ask something, you clarify, you respond to them in a professional manner. You appear confident, and confidence comes from your knowledge. If you know your department, if you know your work, if you know your role, automatically that will be displayed in your communication. You are soft and polite. You are not, rude and aggressive, but you are answering them in a very confident and a polite way. And at the same time, you are assertive. We will talk about assertion at length in a while, in the next session, rather. But the whole idea is that if we know how to handle difficult situations without being aggressive, you will be able to manage those situations very well and avoid any kind of aggressive reactions. As I said earlier, that if we are not using the right tone of voice, it can lead to violence. So we have to be soft and audible and confident. So sometimes people are very soft, but they are not audible. Again, that's a failure of communication. A lot of people say, no, I'm very soft. What is the point of being soft if you're not audible? A lot of people start talking in an appropriate tone of voice, but when they end the conversation, it is not audible. Again, that's not right. So voice modulation, where you know where to give emphasis, so you have to, increase the volume, or where you want to give pause and give them a feeling that it's an important point that you're talking and you want to give them a chance to ask a question or clarify. So that's how we have to use voice modulation to emphasize a point or to, give them a chance to ask something if they want to ask. Another important point in the, paralanguage is the speed of talk. A lot of time people talk at a very high speed. See, when you are talking, the other person may not exactly know what you are saying. And then when they're listening, they need little more time to even comprehend. Especially, for example, if you are talking about, say, explaining them a disease condition or their treatment protocol or the options available. So for you, those terms may be very, very regular. You're using them on daily basis. But for the patient, those terms are very new and unfamiliar. So automatically, they will not understand what we are saying. So we need to really regulate the speed of our talking depending upon with whom we are conversing. Especially there can be a challenge with the language skill. The person may not be even familiar with the language that we speak. So they're already struggling with that. And over and above that, if my speed of talking is fast, or even pronunciation, people have different pronunciation of different words. That can also create a lot of confusion and misunderstanding. We all know that different people speak the same word in a different way, pronounce it in a different way. So that itself causes a lot of difficulty. I'm going back to the language part once again because we missed a small part and I don't want to miss that. Give me a second to go back to the, couple of slides that I want to cover under the language part. Because we talked about the disrespectful language and other aspects, but I want to cover about the written communication part because that's also part of the. So this we have already covered, the common errors we make where we use disrespectful language, rude and authoritative, or we snub others, or we don't use basic courtesies also. So that's all, these are common errors you will see, especially when people are, in a position where they can walk over others. With patients, a lot of time we fail to use the right language. For example, let me show you a slide that I want you to read. So read the following paragraph. So what did you understand?
The iron oxides are known as rust. That's what.
Come on.
Not much. Honestly, let's be honest, not much. This is what exactly happens when you explain to your patients about their diagnosis, their treatment, their intervention. 50% of the patients and their family members do not understand much when you explain them about it. Because the vocabulary we use is so technical for them that they don't understand. And a lot of times, they are very economical with words. We assume that they have understood. But honestly, they don't understand. Now, coming to the written communication, especially in healthcare, written communication plays a very big role. Because when we are writing patients, case file, or we are writing treatment, or we are writing referral notes, or we are writing procedure notes, everywhere it is the written communication that we have to make. And plus, we all know that it is a medical legal document. Whatever you write on the patient case sheet is a part of a medical legal document. Now, I'm showing you a couple of samples of what kind of documents are we creating. This is one sample from a government hospital where a resident has written about a patient. You can very well see the language in writing and no signatures, no patient's name. Who has signed this? Nobody can make out unless you really investigate. Look at this one. What do you notice in this? This is supposed to be Lama summary. Again, patient's name, age, sex, UID number, everything is missing. Then there is correction also, overwriting. The risk is if you overwrite, there's always a risk of error. Look at this one. The name I had struck because I didn't want to disclose the patient's name, but look at the prescription for the patient. So what I want to say, these are common errors you must be coming across every day. Of course, in most of the corporate hospitals now they have gone for, printed output rather than the handwritten prescription. What are the common errors that you notice in the written work? Write in the chat box. What are the common errors you notice in the written work? Absolutely, bad handwriting. Agreed, Arshia. Handwriting is the biggest challenge. Illegible handwriting. There was a saying a time ago कि डॉक्टर की हैंडराइटिंग सिर्फ केमिस्ट ही पढ़ सकता है. अब केमिस्ट भी नहीं पढ़ पाता कभी कभी. No patient identification. Yes, a lot of times that information is. Yes, Michelle, very right. No signature. I was interacting with a group of residents. I said कि ऐसे क्यों करते हो? कहते मैम हमें सीनियर ने बोला एक चिड़िया बना दिया करो ताकि किसी को पता नहीं लगे कि किसने साइन करें. Tell me, is it difficult to find out whose signature is this? It's very easy. It's just a matter of little effort, and you can find out किसने लिखा है. Medicine in learning handwriting. Yes, Shikha, that's another common problem. Medication in small letter. Yes, that's another challenge. Absolutely. Repetitive information. Yes. Instructions which are not clear, not readable. Absolutely. So you will see a lot of time errors. Okay, there's one more. No dose written. Absolutely. So you will see a lot of time problem with the handwriting. I think that's one challenge you will come across a lot of time. People use a lot of abbreviations which others do not understand. Even if you are using a standardized abbreviation, please remember who is going to use this document. If this is for the patient and if you are writing BD, OD, TDS, SOS, they won't be able to make out. We have seen a lot of patients taking medicine when they have written SOS. They don't know SOS is only if it is required, but they don't understand that. Then, of course, overwriting is a very common problem. This we have seen a lot of time. Done but not documented. This is very common. So I was taking a session for a group of gynecologists. So one of them shared her experience. She said, a patient came in I think I've shared this last time with all of you, that a patient received magnesium sulfate dose twice. This I shared last time. The resident who gave the medicine did not, document. Patient received the second dose. Common mistake you will also see is documented but not done. Nurse goes to give injection to the patient. The patient is not in bed, maybe has gone for some referral or some procedure. So she comes back and she just signs in the register thinking, okay, by the time I finish my work, I will give the injection and do. The patient does not come till she is there. She forgets to tell to the next nurse. The injection is lying on the trolley, but nobody knows whose medicine it is. The patient has not received the dose. But it is documented. So how do you know which patient hasn't received the medicine? You will see this very often. Another common problem, document not signed, dated, and timed. I think this is very, very common. Very, very common. Language is a barrier, we all know. So very often you will see people do not have good writing skills. The problem is this is not part of their training. Tell me how many of you have actually received training in creating documents? Whether it is the case file or referral note or surgical notes or procedural notes, I don't think any formal training is given to our medical or nursing professionals.
But ma'am, these days, due to NABH and other accreditations, doctors are trained on these things. But unfortunately, we are not using it, even nurses sometimes. But they are being trained because of these NABH and Kayakalp and other things. Documentation is foremost important thing. So,
Shikha, the problem is I'm also an assessor with NHSRC
yes.
and COAS. Honestly, the problem is a lot of things happen on paper and they are copy pasted. But in real sense, when it
we are
comes
doing this.
we
are doing this. We are giving training and lots and lots.
I'm glad that's happening. I think that's a very good sign. That's a very good sign. But we are far away from the expected, performance.
And
But
also
I'm glad
documenting it at the right time, because usually what happens, the same thing would be documented after the event has happened.
Yeah, exactly.
So we would find the notes, but at the right time is also very important for that point.
Absolutely, absolutely. So I'm not saying all are failing. I'm not saying nobody is doing. What I'm saying, commonly, this is what you get to see. And these errors can cost somebody a life. This can have fatalistic consequences. That's what I'm trying to highlight here. Okay. So paralanguage we have covered and we have talked about it. So we go further and let me go to the next slide. Okay. Give me 1 second. Okay, now we are going to the body language. So we have covered language and paralanguage. We are going to the third part of the communication, and that is body language. So what do you see in this picture?
खा
What is-
जाएगा तो फोन के दूसरे तरफ है उसको.
It's very annoying.
Must be shouting on someone.
Shouting at someone. Very, very agitated, very aggressive. Now you see, we have not even heard single word, but from his body language, we can make out that he is really, really very aggressive. As I said earlier, 55% of the communication happens through our body. And the way we sit, the way we stand, the way we, use our hands, body language, it all communicates. It all communicates. Body language includes everything from your facial expressions, eye contact, gesture, posture, touch, space, everything. So publicly, when we sit and stand, even that's a communication we are making. And your body language has more impact than this. Let's do a small activity to understand this. Set your hands free. Make yourself comfortable. Whose camera is off? Come in, please, Arshia. Okay, thank you. So I'm going to take you to your childhood. You have to play with me. So what I speak, you have to speak with me. Let me give you one example and then. So you remember that poem? If you're happy and touch your nose. Everybody remembers? Okay. So we'll do it once, we'll do it slowly, and then we'll do it little fast. If you're happy and touch your nose. If you're happy and touch your ear. You have to do with me. Everybody has to do. And if you're happy and touch your nose. If you're happy and touch your ear. How many of you touch your chin? Tell me. Raise your hand. Actions speak louder than. When we say, no, I'm not shouting at you. No, I'm not shouting at you. I'm asking you to speak. Why are you not speaking? I'm giving you a chance to speak. Why don't you reply? I'm waiting for you to tell me. Now look at my body language. Are you really listening to what I'm saying? From my body language, you can make out that I don't want you to speak a word. That's what exactly happens when we are communicating with people. So when we are talking to people, people are not listening to your words. They're looking at your body language and they get an idea whether you're aggressive, non-aggressive, happy, unhappy, agitated. So we have to be very careful with our body. So tell me, what are our usual facial expressions when we are interacting with our patients or their family members? Number 1, 2, 3, 4, 5, 6. Which one? Number?
Number 1.
1.
9 o'clock. What about 11 o'clock?
Always.
Okay. So any other guess? Okay. If you say that you always smile, I'm very happy to hear this. But usually you will see healthcare professionals interacting with their patient with facial expression number 5. And what is in number 5?
Blank.
Blank.
Expressionless.
No expressions. Disconnect. And why do we keep that face?
Like the poker face.
Take out all frustration on patients.
We don't want to connect with the patient. We feel if I smile, the patient will cling to me and will ask more questions, and I will have to give time, or may ask me for something that I don't want to do, but I will have to oblige. So it's better to have a face that kind of intimidates and puts the patient off.
Also, at one point of time, we get connected at a personal level to the patient also. Which if the results are not fine, that at some point of your mind, it also hurts you. Like, you get that emotional connect. Because when I was treating my patient, that always used to happen. If something happens to my patient, I'll carry that everything at my place. That was one also, I believe.
So this is a very common explanation I receive from doctors. With the residents, especially, they say that our seniors have told us to keep this space, one, because you don't have to connect with the patient. Connecting and attaching yourself are two different things. Connecting is important. Attaching is not desired. When you attach with the patient, then you are emotionally engaging with the patient, which is not right. That's going to impact your mental health. But connecting with the patient is important because patient has to feel that there is somebody who is there for me, who is looking after me, who knows my status, who is in the know of what my needs are.
I think it's more of assurance in your face should be there. And maybe
Compassion, empathy, assurance, all that are required to be communicated through your body language. Emotionally, you don't have to connect with the patient, because when you connect, then you start kind of engaging at a level where it is going to affect you. Then there will be a transference and counter transference. You will start looking a relative of yours in a patient, and patient will start looking a relative of theirs in you. That's not desirable. So you have to stay friendly but professional. You don't mingle at a personal level. So you don't talk issues either in their personal life or of your personal life. But whatever is related to the patient's recovery or care, that is where we have to participate as a therapist with. So there has to be a clarity. And we'll be talking about it further also, but I'm glad that you brought this up. But my question to all those who say that we don't have to, show any expression on the face, will you be happy being treated by a doctor or a person with facial expression number 5? No.
No, no.
Never, never. You expect the person to smile. That gives you, okay, this person is nice, is welcoming, I'm accepted, and I am being attended by a person who is willing to help. So through your facial expression, you communicate a lot. A lot of time when we don't smile, it communicates that I'm there, but I'm not there. That's the tragedy. So you can smile, but if the patient tries for secondary gains, a lot of time patient tries to be friendly, especially with female doctors and female nurses, they'll start trying to mingle up. कहाँ रहते हैं आप? आपकी शादी हो गई है ना? They'll start trying to. That's where you have to learn to assert and draw a professional line. But we don't have to be rude and aggressive and disconnected from it. So if we have expressions of anger, irritability, unhappiness, or our negative attitude, it is visible in our body language and facial expression. And we need to be mindful of this. Especially when we are interacting with patients, if we start looking away, or we start staring at them, or we look sarcastically, or we close our eyes. So these are all ways we are some kind of communicating, I'm not interested in you, and you are wasting my time, and I don't have time for all. So these non-verbals have to be avoided to kind of not send a wrong signal to the patient. Eye contact. Why is it important to make eye contact?
Shows attention.
Sorry.
You're being
repeat.
attentive.
Yeah, that shows that you are attentive. Okay. What else? How else does eye contact help you?
I think it's more of trust which comes to you when
So when
talk
you're
with an
making eye
icon.
contact, you are able to demonstrate trust and also win your patient's trust. Okay, wonderful. What else?
The person cannot just lie or something when you're going to have an eye contact.
Absolutely, Maheshwari. Excellent. I think that's one of the biggest benefits. When you make eye contact, you are looking at the patient face. So if the patient is telling a lie or is hesitating or is scared or is uncomfortable, intensity of pain, general condition of the patient, all that you can evaluate when you make eye contact. Of course, concern, compassion, trust, all that is communicated through eye contact. I'm listening to you. That also is communicated when you make eye contact. So making eye contact is one of the first, far most important, gesture that's required when you interact with anybody. And the protocol in that is when you make eye contact, make sure that in a professional setup, you look at the eyes and then above the eyes. Of course, you will be able to see the whole face, but do not avoid looking at the eyes and below the eyes. In personal relationship, we can see eyes and below the eyes, but in a professional setup, especially with strangers, they feel uncomfortable when you start looking down the eyes. And the protocol is look for 2 to 3 seconds, shift your focus. Even when you're talking to them, deliberately shift your focus. You can come back. Shift for your focus for a second and come back. Do not steer your patient. They'll become uncomfortable. And never look from head to toe. That would make the other person feel uncomfortable. But making eye contact is definitely very important. In this picture, there are 2 postures, A and B. Which one is okay? A or B?
Not both.
What do others say?
I don't go for both.
Yeah, neither.
Excellent. Both the postures are not okay. In the A, the person is appearing very casual. In B, the person appears closed. So both are not okay. Especially, I have written very clearly, when you're sitting in a chair, please do not rock in the chair. That gives a feeling that, again, I'm not really connected with you. The right posture is when you slightly lean forward. When you lean forward, make eye contact, nod, that shows that you are participating and you are listening to them attentively. So we have to be very careful about the posture when we are interacting with patients and the family members. Touch, another important, non-verbal communication. So what challenge do we see in touching the patient?
Culturally, sometimes it might not be appropriate, maybe for the opposite gender to be touched. Also, the place where you want to touch, so appropriate, so maybe head or shoulder or hand, depending on.
Absolutely. So there was a time touching on the shoulder, touching on the arm was considered like, kind of communicating concern and compassion. But we really need to be very, very careful now. Although touching in healthcare is unavoidable because you have to examine the patient, you have to touch the patient. But please look at it from the patient's point of view. They may not feel very comfortable when you're touching, especially their, area, part of the body that's covered. So we have to be all the more careful when we are touching the patient to, first of all, communicate that I'm going to touch you. So signpost, seek permission. That's very important. So, and we all know that touching on the shoulder and hand and head communicates compassion. But we also have to remember that it can create misunderstanding, especially with the opposite sex. Even when you are going to touch the patient for examining, we have to signpost. For example, if I'm going to even check the pulse of the patient, I can't pull the patient's hand and just start. I will have to verbally say, I need to check your pulse. Are you okay with it? So when you say, are you okay with it? It's more like a giving an opportunity to your patient to say no if they don't. See, usually, especially in OPD, we assume that there is a, you know, the patient knows that I'm going to be examined. Even if the patient knows, but we say it's an implied consent. We use that word implied consent. Please remember, you know what is implied consent. Patient does not know. So for that, we have to inform the patient that I need to check your eye. I need to check your ear. No, I just don't go close and just start examining. I will have to sign first and also seek permission. There are patients who do not like to be touched by a person of the opposite sex. And if they say that no, I want to be examined by a female doctor, then I have to respect my patient's desire.
And I had one. Sorry.
Yeah, go ahead.
With regard to pediatrics, would this change in terms of it? Because I've noticed, like, especially with kids who are undergoing cancer treatment, a lot of people pinch their cheek, touch their face. We've had kids who are even as young as 1.5-year-olds who come in for treatment. And so I think that's one of the things. And same thing happens with geriatrics who are like in their 80s and 90s, right? Who might have dementia or, So I'm guessing these rules hold good for those age groups as well.
Michelle, you really raised very, very interesting points. I think that they're very valid points. Absolutely, I completely agree with you. Touching the child on the cheek or ear, and sometimes we pull the arm, not a right way. We think we are building rapport with the patient and we are making the patient comfortable. I don't think even parents see that in a good light. But then, they think it's all right because we are here for treatment. But we have to actually be more mindful of our touching. Any unnecessary touching is undesirable, should be avoided. It can have its own implications. So one has to be careful. And we have seen, yes, please go ahead. Yeah.
Ma'am, can I add one thing? Ma'am,
Sure.
if we have to examine the opposite sex or we are touching, what I usually prefer, I want a female attendant has to be there.
Absolutely.
Without the presence of the female attendant, whether it's she's from their family or hospital employee.
It's mandatory. I completely agree with you. Either it has to be patient's family member or one of the hospital staff, female staff, has to be there, so that there is somebody and that's the care I think everybody should take. I remember I was taking a session somewhere, and it was, I think, the patient got her ECG done, female patient, ECG done. So this is the case I'm talking about almost 25 years ago. There at that time we didn't have any female ECG technicians. Of course, we have female ECG technicians. So it was a male technician who did the ECG for her. This lady got the ECG done and she came out and she went and told to her husband that my ECG was done by male technician. That man literally came in, and caught hold of this person's neck. How dare you touch my wife? Because we took it for granted that if the patient has come for ECG, and if it is the male technician, she will have to get it. Sorry. But we have to be now more careful and more understanding that, we have to see how we can make our patient feel comfortable and safe also. And as you said, during physical examination, we have to have a female attendant with the patient. Absolutely. Completely.
Ma'am, I had one more, not
Sure.
so pleasant, but almost in the same lines experience. So this is a family friend of mine who happened to go to a general physician who was extremely and she went there asking for a consultation for her mother, who's 82 years old and had dementia, but she was also a ovarian cancer survivor. When she went into the consultation, they started talking about her mother, obviously, but somewhere in the conversation, he said, "Oh, why don't you come and lie down and let me examine you?" And she, even though she's known him for almost half her life, he's a very senior, almost like a family physician. She
Hmm.
came out of that consultation saying, I felt like I was being like groped. Because he did a breast examination and there was no female attendant, and it was all like, oh, everything's fine, everything's great. And she said, I came out feeling, and she's not married. So, and she's in her 50s. So I think sometimes even known people, if this is going to happen, then it can be extremely
Very disrespectful.
disrespectful. And
Absolutely. Absolutely. Especially with relationships where you have that trust, there you feel all the more wrong. I understand. I completely understand. That's very sad. And one person doing this would actually bring bad name to so many others have. And there's a loss of trust in the whole, that's what is exactly happening. Absolutely. Thank you for sharing that experience. Okay, so what kind of hand movement do you think are undesirable? Or you have seen people doing which you think are inappropriate?
It's a very usual expression what I've seen. Like when you go to someone and like
One is coming in and you say,
and it's like the expression like he, as if required or unwanted. Why the hell are you coming here? Just move out. And I have seen a lot of seniors doing this, and this bothers you a lot.
absolutely, it's very upsetting, very, very upsetting. Absolutely true. Ab bahar ho jao, chalo bhai, move out. That's another usual thing you will get to see. What else? What else? What can I do? I can't help you. And a lot of time we point to the diseased part of the body using finger. That's again a very undesirable kind of a gesture. So we have to be very careful when we are using hands and not fingers. So when you make expressions like this, it communicates that I can't do anything. Or when you stop like this, like Miki just now said, it's a very disrespectful way of stopping somebody. So all these kind of hand movements should be avoided in public interaction. Okay, whom does he look like? Whom does he look like? Whom does he look like? So dressing plays a very, very big role in the way people perceive us. Especially with young adults, we get to see that they're not very particular about their clothing, their dress. And a lot of time, just because of inappropriately, being dressed up, they are not respected by their patients and their family members. As I said, I work with medical interns. A lot of time they come and tell me, ma'am, patients, sometimes, especially with female doctors, they say, "वो मुझे sister कह के बुलाते हैं," patient. And male doctors will say, कि मुझे वो doctor ही नहीं समझते हैं. So if you want to be treated like a doctor, you have to look like a doctor. And especially see, they are going to hand over their life in your hands. And if you don't look, responsible, they will never feel safe. We see a lot of time residents and, people wearing chappals and then jeans. And I see a lot of people wearing high heels. Recently, I was at one hospital. Where did I go? Yeah, I had gone to a medical college for that keynote address last week. The girls were wearing this high heel. I was wondering how do you work, especially in healthcare, you have to run up and down and you have to do so much of work. So we got to be careful about the way we dress. Even clothing, the color of your clothing is very important. So when you wear bright colors like yellow, red, blue, they're not very appropriate in healthcare setting. Of course, in your personal life, you can wear what you like. But at a healthcare setup, I think we need to fine-tune ourselves with the patient's surrounding. 3 questions that will help us to decide whether I should be going for this cloth or not are: are these clothes comfortable? That's the first question we should ask ourselves. Second is, does this cloth fit me properly? Sometimes the cloth is very nice, I really like them, but it is either too tight, too loose, too short, I wear and go, not a good. And then of course, am I dressed appropriately for my position and responsibility? So I think all of us have to remember that we have to dress up appropriately as per our position. So I take sessions for Delhi Judicial Academy where the young magistrates,
Right.
SDM, it is, subdivisional magistrate. The young judges, they come for their induction program and I take a couple of sessions for them. So there I saw one day they were arguing with one of their senior. Why are we expected to wear saris and these kind of clothes? Why can't we wear what we like? They have to understand, see, we have a very, high pedestal for certain positions. So we want people to match their position so that we can, respect them. So same way, I think in medicine and in healthcare also, we have to make sure that we appear professional. And people actually from your appearance decide how intelligent or professional you must be. Although it may not be appropriate, but then that's how the human mind functions. Next is personal space and privacy. See, we all carry a bubble around us, and we like people to maintain that safe space for us. But when you kind of get into their personal space, they feel uncomfortable. A lot of time we have to do it, especially when we are doing when we are doing some examination or we are doing some procedure. But then again, it's not very comfortable to have somebody very, very close to you. So what is the appropriate distance that we should maintain generally? Any guess? An arm's length. That is C. So around 2.5 feet distance is appropriate when you are, of course, if you need to, go closer for examining, for example, if you want to examine fundus or you want to examine ear or throat, you will have to go closer. So it's better if you signpost before you go close and then seek permission so that they have an opportunity to say no if they are uncomfortable. Respecting patients' privacy and confidentiality, another important aspect of patient. A lot of time we do not care much for it. We have seen when we are examining the patient, we have our colleagues coming in and going out. We have people from our own department coming in and going out. The patient is lying, half covered and half uncovered, helpless, can't say anything. So we need to be more mindful of the situation. I mean, just imagine yourself in that position. Nobody would like to lie down. So this is another picture sent to me by one of the participants of the program. So this is the then the health minister, and he's WHO director, the other one. So they are, there's a patient lying on the table, and look at the way they are all looking at the patient. We need to be more mindful of that. Another important aspect of non-verbal communication is valuing patients' time. A lot of time we make them wait. And a lot of time we make them wait unnecessarily. And a lot of time we make them wait and then we say, sorry, machine kharab ho gayi hai. Aapko dobara aana padega. I think it's time that we respect patients. We have to make all efforts to make the patient wait for minimum time. And also the number of visits should be kept minimum. So the whole idea of this discussion is we have to remember that we have to display respect and care at every point of contact. Because it is not just doctor's responsibility. Anywhere they go, it could be radiology, pharmacy, lab, front desk, wherever they go, all of us have to remember that we have to be more mindful of our language, our body language, our tone of voice, and the way we come. So there are couple of skills that I want to recommend. All that we have discussed. If I say, and especially when you are training others, if you tell them that these 5 skills, if you can keep with you handy all the time, you will never fail to communicate. And I want to introduce those 5 skills to you to summarize what we have discussed. The first skill that I want to talk about is the concept of building rapport. What is building rapport? I think that's the first skill that we all have to practice if we want to really connect with our patient. What is building rapport?
To make the patient or family member comfortable.
Okay.
Break the ice.
Be a good listener.
Okay, be
Giving
a
us-
listener to break the ice. Very
Giving
good.
a safe space to share.
Absolutely, giving them safe space to share. Absolutely.
Showing interest.
Showing interest. Okay. So if I may briefly say, building rapport is creating familiarity and comfort with the patient. But my question to you is it only for the patient? Is it not important for us? So it is for both the parties. So it is creating comfort and familiarity for both the parties. It is not just for the patient. Even we need to become comfortable with it. Even we need to become comfortable to talk about some issues that might come up, which are very intense. And we also take time to, calm ourselves and then start interacting with them. How much time does it take to build rapport? Guess?
Less than a minute.
Okay. Any other guess?
To interact with a stranger, you see?
Building rapport. Stranger, of course, patient would be a stranger, especially when they come for the first time.
5 to 10.
2 minutes.
5 to 10.
2 minutes. Michelle, what did you say? 2 minutes?
5 to 10.
5 to 10 minutes. Any other guess? Arshia?
5 to 10 minutes.
Okay. Shikha? Guess?
On the interaction, 5 minutes.
Building rapport does not require time. It's more a matter of intention. A patient comes in, I'm sitting on my table, I'm doing something, I don't lift my head. I continue doing what I'm doing. Patient is standing right in front of me. I don't offer a chair. I don't ask why you are here. How can I help you? What's your name? Whatever. I make the person wait for some time. I'm working, patient comes in, I lift my head, I look at the patient, I smile and say, आइए, बैठिए, क्या नाम है आप? कौन है आपके साथ में? The rapport building has begun. It's more of a factor of intention to build rapport. We work, but we don't build rapport. Whereas if you build rapport, the further conversation becomes so very easy and smooth. It opens a gateway where the person suddenly starts feeling comfortable. Oh, nice people. Nice. आप किसी होटल में खाना खाने जाते हैं, एक जो उनके जो स्टाफ जो होता है, not just the waiter but generally, if they come and say नमस्ते मैम, कैसे हैं आप, they offer menu. एक आता है सिर्फ मेन्यू कार्ड फेंक के चला जाता. How do you feel? See, we can't deny the fact that now hospital industry has become hospitality industry, whether we like it or not. If you are charging, you are hospitality industry. If you are giving it free, then you are only helping. Now you are charging. So you can't say, ki, I will charge you, but I will not serve you with smile. Let's do a small activity to understand how does building rapport. One more question before we go further. Is it becoming friends with the patient? Is it being friends with the patient when you build rapport? People fear that. That's why I'm asking you this. That's why they don't build rapport. It is not being friend, it is being friendly. So sometimes, like when interns tell me, कि मैम time ही नहीं होता build rapport building का, तो मैं उनसे पूछती हूँ कि what is your job? I think two things interns do. One is to go and collect blood sample, and second is to write their discharge slip. And then I ask them, when you go to take blood sample, how many of you look at the patient face? How many of you ask you, नमस्ते, कैसे हैं आप? कैसी तबीयत है आपकी? आज तो अच्छे लग रहे हैं आप, कल से तो बेटर है. दर्द कैसा है? No, you just go and just tie tunicate and then take blood and then you come back. So rapport building कैसे होगा? So let's do a small activity. I'm going to put you in the breakout room. I'll be creating 3 breakout rooms and I'll be sending you in pair, 2 persons in one. It will be at random. I'm not choosing anybody. It will be automatically. So you have 3 minutes time. So in the first 1 minute, one person will do the talking and the second one will listen. Then in the second minute is for the second person to do the talking, and the first person who was talking now will be listening. And 1 minute extra, that in case if your conversation stays incomplete, then you can complete your conversation with each other. And the prompt for discussion is, if I was not doing what I am doing in my profession, where would have I been? For example, if Dr. Pradeep was not doing medicine, what would have he been doing? Save Michelle, Neetu, Arshia, whatever you're doing, whatever profession you have chosen, if you were not in that profession, where would have you been? Is that okay? Any questions? Okay, so I'm going to create breakout rooms and I'm going to send you. Please join your, you will get a prompt to join, so you will have to join automatically. Okay. One minute is over, you can change your role. 1 minute left. Okay. So how did it feel being there? Did it break some ice?
Yes.
Did it create some familiarity? Some more comfort?
Yes.
Imagine if just 1 or 2 minutes of interaction can bring this change. But if we, proactively created comfort with the patient, how good they will feel with us. So the first skill that we have to practice with patients, with everybody rather, why only patients, even with fellow professionals. I remember I was taking a session for one of the hospitals, and the head of the department said, I know this nurse, she's working with me in my department. He was in anesthetics, he's the head of the department of anesthesia. He said, I know this girl, she's working in the ICU for so many years. I've never interacted with her. We did the same activity where I made them talk. And then he said, I never discussed anything like this. I never had a chance to talk. That's the power of learning. So proactively, when you try to strike conversation with the patient, with your family members, with your juniors, with your staff, it breaks ice. It opens an opportunity for a long-term association, long-term working. So that's the first skill that I want to communicate. The second skill is prompt attention and attentiveness. When people talk, they expect the other person to pay attention and listen. And Maya Angelou, she says there is no greater agony than bearing the untold story inside you. We normally think we listen, but you saw in the last activity that we did last session that we think we are listening, what we do. Let's again do an activity. That's the second activity. Now I'm going to put 3 of you from the pair. Okay. Maheshwari, who was with you?
Shikha was with me.
Shikha was with you. So Shikha, I'm going to, okay. First of all, to those 3 to whom I am going to send to the waiting room. So I'm going to send you to the waiting room to recollect an incident where you did something very good. Either your patient or your senior was very happy with the way you handled the situation. So I'm going to give you a minute's time to recollect that, incident, because you will have to come back and speak to your partner. So Maheshwari, Shikha was with you. Hmm? So Shikha, I'm going to put you to the waiting room for a minute so that you can recollect that incident and come back and narrate that to Maheshwari. Is that okay?
Okay,
And
ma'am.
so I'll be sending you to the breakout room. Okay. Okay. Michelle, who was with you?
Dr. Pradeep.
Dr. Pradeep. So, Dr. Pradeep, I'm going to send you to the waiting room and I request you to recollect any incident that happened where either your patient or their family member or one of your colleague was very happy with the way you handled the situation. Is that okay? Okay. And Arshia, who was with you? Me too. Okay. So, Mitu, I'm going to put you in the waiting room to three of you. So I'm sending Shikha, Dr. Pradeep, and Mitu. So let me first put you three in the waiting room. So, Mitu, you are going in the waiting room. Okay. So, second is Dr. Pradeep. So, Dr. Pradeep, I'm putting you in the waiting room. Two. And Arshia?
No, Shika.
Shikha.
Dr.
No,
Meetu. Dr.
Shikha,
Meetu is not.
Shikha is here?
Shikha has
Yeah,
to.
Shikha. Yeah, Shikha, because you switched off the camera, so I got confused. Okay. So I'm putting in the waiting room. Okay. Okay. So three of them have gone, and now I have three of you. Is that right? Okay. So friends, the activity is that they are going to come back to you. I'm going to put three of you in the uh, breakout room, but they'll come back with a story. They would want to share that story with you, but you don't have to listen to them. So you will have to kind of show as though you're not interested. So maybe you will either start talking on phone, or you will switch off your camera, or you will start writing something, but you have to kind of demonstrate that I'm not listening. Is that okay? I'm sorry, but that's how we have to do the activity. So I'm creating three breakout rooms and I'm putting three of you. Uh, okay. Yeah, I think same. Good. So you're going to your breakout rooms. So you have to join the breakout room, all of you. Please join the breakout room. I hope you got the notification. Not yet? Uh, okay. So I will put you. Mm, Give me a second. Sorry, why is it not happening? Okay. So I think I'll have to do it again. Let me call them back. Let me call them back. So I'll have to call all of them. Give me a second to So I'm going to create the breakout room once again, and you will get the notification. Please join. Huh? Why am I not? Okay, those all breakout room. Okay, and then again you get the notification. Yeah, please. Thirty seconds left.
Dr. Indu, I want to hide.
I think I should be apologizing first of all to all those. So what was the experience?
दीवार से बात करना.
Shikha, Arshia, and Satutali.
I think for me, it was दीवार से बात कर रही थी.
Oh my goodness, I'm so sorry.
Maheshwari listened very well.
Is
And
it?
he corrected me also. I thought I have to share both the side we have to share, but he said no, you only have to share the things.
Okay. Okay. So she heard you.
No, Michelle is a good listener, and she was listening to me. She was interacting in between also.
So were you happy with the interruptions?
Yeah, yes.
So the whole idea was actually, I don't know that these people failed me. I told them.
I didn't fail you.
Clearly, we are
Dr.
bad actors.
I didn't
I
fail you.
wasn't
Yes,
having,
I didn't fail you.
I was moving this side. I was closing my eyes. I did all sorts of stuff, but still she didn't get annoyed.
See, the whole activity was that these people were supposed to not listen to you.
Okay.
That was the idea. So they were supposed to show that I'm not listening to you. I wanted to give all of you a taste that this is what the other party feels when you don't listen to them. That was the whole idea. But I think
Okay.
Michelle and Maheshwari got interested and they were listening to you attentively. But I think Arshia played her role well.
Sorry, Dr. Gita, I was like, I was quite in my role. So
I know, and at the end, what she said, हो गया.
for
मैंने
that.
बोला, हाँ, हो गया.
But Mitu, how did you feel when
I was like, oh my God, David, सुना ही नहीं, इतना सुना.
So we should have seen that actually scene, you know.
But
So
I had to smile, saying like, okay.
So this was just to give you a feel that when we don't listen, people get to see that we are not listening. From our body language, from the way we look at them, or we don't look at them, or we are doing something, they get an idea that we are not listening. And that's very hurtful for anybody, that you are talking, but the other person is just not listening. So I think it's very important to not only listen attentively, but it is important to also showcase that I'm listening to you. As I said earlier also, there is no greater agony than bearing an untold story inside you. When patients come to us, they have to talk about their problem. They want to share with you. They want to make sure that they have told you all important information. But for us, probably it could be something that we know and we are not interested in knowing more. And they really feel bad. And a lot of time I get to hear from the patients also, उन्होंने मेरी बात ही नहीं सुनी, उन्होंने मेरी बात को ध्यान ही नहीं दिया. So it is not only important to listen, but we also have to demonstrate that I'm listening. And for that, I think the first important thing is that we should face the person, especially in the era of technology coming in the healthcare. We have always a laptop or an iPad or a computer in the room. It's always called third person in the room because we are busy simultaneously typing the information and we are not even facing the person. So that person feels I'm not being given 100% attention. So we have to first of all face the person, make adequate eye contact. It's okay if you are typing simultaneously because you need to put the record on the computer. Why not tell the patient and do it? Like, I'm going to simultaneously put your record on the computer, so I have to type meanwhile. But also make sure that in between you stop and you look at the patient and make adequate eye contact, especially if they are sharing something very vital. So at that moment, I will have to put my typing on hold and look at the person and demonstrate that I'm listening to you. If everything is okay and it is appropriate to smile, there is nothing wrong in smiling. That would put the person, make the person comfortable. Please do not do multitasking, especially when they have come one-on-one with you. You have to stop and put things on hold. Leaning forward communicates interest because that shows that I'm trying to connect and I'm trying to reach out to you. Nodding helps to communicate, I'm listening, I'm understanding, I'm agreeing. And then, of course, in between, when you interrupt the person, their flow gets disrupted. So it's always good to note down the important point or something that you want to clarify. After they have finished, you can always ask a question, anything that you want them to elaborate or you want to clarify something. So make sure that you kind of give them that opportunity to share what they want to say. How much time does a patient take to explain about their condition? Any idea? If you allow the patient to speak, just guess. Just guess.
5
In
to
how much
10
What-
minutes.
45 seconds to 1 minute.
Very close, very, very close. A patient is able to mostly tell about their problem within 60 to 80 seconds. And if you allow the patient to speak for 1 minute uninterrupted, their satisfaction multiplies many-fold. They feel very happy and satisfied that I have been heard. I have been able to tell my story. Then, of course, you can ask the questions that you want to ask. But that 1 minute, if you give them to speak, they're more than happy. So there are actually 3 more skills that I want to cover, but I can see it is already 10 o'clock and I don't want to hold you, beyond 10 o'clock. In any case, I was thinking that this part I will cover in the next session, but since we had time, I thought let me cover. So these 2 skills we have talked. There are 3 more skills that I want you to, understand. We will cover them in the next class. Any questions about what we have discussed till now? Questions, feedback, comments, anything that you want to see. Are you finding it useful? Is it engaging? Are you learning? Is it something good? Whatever you want.
So from my side, ma'am, at present I don't deal much with the patients, but whatever I am learning from here is exactly I can feel how somewhere I also behave with my juniors, and somehow my seniors also behave with me. And it's a lot of time. You have so much of clutter in your mind. जब हम बोलते हैं कि सामने वाले का सुनो, उतना माइंड प्रोसेस ही नहीं कर रहा होता. मतलब there's already multitasking going on. It's like ये जा रहे हैं next meeting, ये जा रहे हैं next meeting. So processing is over fast at that point of time. And I think the communication way, the way you said, the body language, we all know. But जब हम expression दे रहे होते हैं, तब हम realize ही नहीं कर रहे होते how are we actually behaving, because we don't see a mirror at that time. But the only mirror is सामने वाले का expression, which we missed it because we are not interested. But I think आज का जितना पूरा session I heard, it's like an eye opener for me also, and maybe from tomorrow I'm going to behave in a much better way with my colleagues and my team, because my task is I do audit, and जब मैं audit करूँगी तो I'll give them something as a negative remark. Now that negative remark, everyone's not ready to take it out, and I am like कि मैंने तो सही किया है, ये क्यों नहीं सुन रहा? So for me also, it's a patient and a doctor situation which comes up. Which I think the session was a wonderful session for me. That's my feedback on that.
Thank you so much. Thank you. Any other comment from any one of you?
Ma'am, I have learned how to engage the audience. These activities are really very helpful that I'm going to incorporate in my own trainings also. And really, it's very interactive also, so that you can build a rapport with your audience too.
Absolutely. I think that's a very good observation, Shikha. This is what I want. Keep an eye on what activities I'm doing. And most of these things, they are given in the booklet, and you're also watching, you're personally attending the program. Then you will have access to the video, which you can revisit and revise whatever you are learning, and try implementing and integrating all this in your, sessions or your talk or your presentation. And there will be a lot of new pedagogies that I will be using. And I request all of you to keep an eye on. Because as a trainer, you will really benefit. See, 2 hours have passed, and I can see all of you are sitting with the same amount of attention and interest. That's how you have to replicate when your turn comes. So I'm hardly using any presentation. I'm trying to avoid using any presentation, but I'm trying to ask questions and make you speak and participate. That is what I want you to learn, besides understanding what clinical communication is. Like Mitu said that she's not handling patients, but all this is in your professional life. You're using with your fellow professionals. And the principles of communication are same across any interaction.
The only thing, how to make them understand.
Absolutely. Absolutely. And how to give feedback, how to give negative feedback, all that slowly we will be touching, although my focus may not be on that much on that, but I'll try to bring in situations where you have to tell something bitter to the other person. We don't have to be rude to tell bitter. I may have to tell something bitter, but I don't have to be rude and aggressive to tell that bitter.
Like while telling the negative things, you have to give simultaneously the solution also.
Absolutely. We'll be talking about it. So the third, all of you have taken that communication style questionnaire?
Yes.
I sent 2 questionnaires. So the second one was to help you introspect, how am I communicating with my patients? If you are doing this behavior with almost all your patients, you're good to go. You're doing a good job. But if you're not doing it with all the patients, but you're doing with only some of the patients, then this is the checklist for you. Please follow this checklist and make sure that you give the same behavior to all your patients. And you will see a sea change in the patient satisfaction and your own satisfaction.
Ma'am, can I ask something?
Sure.
Do we get these questionnaires also? I mean, we have filled these questionnaires, but do we get these for the future references?
You have access to the questionnaire. Note them down. Create your own Google form.
No, because for the past 2 questionnaires, I haven't.
If I give you Google form, see, I can give you everything, but then if you create yourself, you will know what I want to ask or what I want to say. I don't share the presentation, but I'm sharing the recording. You can make your presentation using the recording. But when you will create your own presentation, you will know what I have to say at this slide. If I just give you slides, then you will just be speaking out of those slides. I don't want that.
Okay.
I hope that helps.
Yes, yes.
Thank you. I've shared the feedback form in the chat box. I request you to give your feedback quickly before we close the session.
I have a small question. So,
Sure.
I mean, though we are talking about what to do and how to do it, but I really want to understand, like Dr. Meetu also shared, there are some real problems or some real reasons because of which medical professionals might be behaving in a certain way at certain times. I mean, just educating them on what is the right way to work with patients, is it enough? Or is it also important to, get to the root cause of why this behavior is coming, to bring out the real and a long-lasting, sustainable difference in how, the patient communication happens?
Absolutely, Karshia. Problems are endless. We are lacking resources, we are lacking infrastructure, we are lacking on number of fronts. But then we can't wait for everything to be there before we start working on self. See, if I go by Stephen Covey's understanding of what we can change and what we cannot change, I think I talked about it in last class. Did I? See, there are issues that are beyond my control. If there are systemic failures, if there are lack of resources, there are lack of infrastructure, they are very genuine problems, but they are beyond my control. So all those things will come in circle of concern. Circle of concern is things that are true, but they are not in my control. If I want to grow, if I want to be happy, if I want to do well, I have to focus on the other circle, and that circle is called circle of influence. Circle of influence will have everything over which I have control, things which I can manage. For example, it is raining outside. Can I stop the rain? That's out of my control. So this will go in the circle of concern. It is raining outside, but I need to go out. Can I do something? I can. I can use raincoat, I can use umbrella, I can even go, without using anything. If it is very important, I don't mind even getting drenched in the water. So very mindfully, we have to focus on circle of influence, things over which I have control. See, these situations, they are everywhere. We are saying that our system lacks all this. Look at the Western culture. Visit some of the, hospitals outside country. They have everything. Even there is violence. They have very systematic way of functioning. They have all the resources. They give 30 minutes to one patient. Even then, the patients become aggressive. They are unhappy. They are dissatisfied. Errors are happening. So we might say, oh, we are very overworked, so we are rude. But sensitizing people, teaching people, educating people is one of the ways to help people understand I don't have control over many factors, but how I behave, how I think, how I feel is in my control. So circle of influence is where I have to focus. So this whole session, this whole program is with the idea that I don't have control over the bigger picture, but I can control my situation. When I started teaching healthcare communication, people said, who will listen to you? Nobody's interested. Nobody. If I heard them, then I would have stopped working. 10 years and I'm still there. That means there are people who are ready to listen. There I am.
One more thing, just the
Okay.
last thing I want to ask. So do you think, so there are like in corporate hospitals, there are feedback mechanisms where, patients give feedback about how their experience with the doctors has been. In your experience, does that really work and does that affect, how the patient and doctor communication in the long run?
See, Arsha, it's a very mixed picture. I've seen hospitals where they're taking feedback very seriously. They go into every feedback, especially if it's a negative feedback, they go to the root cause, they try to correct the situation, and then they also even inform the patient about the action that you have taken to their feedback. But in most of the hospitals, I see feedback is more like a mechanical activity, which is not taken seriously, and especially if it is against any senior person, where they know that they are powerless to do anything, they just take it with a pinch of salt. That's okay. That's the reality of the situation and circumstances. I would again say, just don't try to look for one gate and try to push that gate. There are many other gates available which you can try to open. Last time also I said, if your consultant is not communicating, have people who communicate and compensate for that lack of communication. So be creative in finding solution to this problem. Again, according to a study by Harvard, there are 4 minimum solutions for every problem. And every solution should be tried at least 4 times before you give up. So there are 16 opportunities to resolve the problem. There will be a time when feedback will be taken seriously. Patients will make us do, I'm telling you. They are very demanding now. Things are changing. See, things are changing. But these are very nice questions you are asking. Thank you. Good. That shows that you are listening attentively and you're also trying to, kind of analyze. Is it making sense? Is it relevant? Is it really practically implementable? That's very nice. Any other question? I'm okay with spending another 10 minutes. I mean, I'm in no hurry. You are free to kind of ask any question. That's the whole purpose of discussion. Although besides this, I really love that healthcare professionals should go for leadership training, because the questions that you are asking are more to do with your, managerial skills. Like you said, I do like this when especially you have to give negative feedback. I give it because that's my job. But I thought that that's the only way of giving negative feedback. Next class, when we will discuss, you will get to realize that you can give extremely negative feedback without being rude and aggressive. And like Arshia is asking about, does feedback help? If my way of giving feedback is in a manner that I'm not giving feedback with the purpose of insulting you or humiliating you, but I'm giving feedback with the idea to improve you, to make you better, feedback will be taken seriously. So these are all managerial skills, leadership skills. I think we all have to learn. So I've received 5 responses to the feedback form. I think one of you are still left with the feedback.
I still have to do that. Just now.
So do you want me to share in the WhatsApp, or you will do it? Sorry, I lost your voice. Arshia, unmute.
It's in the chat box, right? It's in the chat box.
It's in the chat.
I'll do that.
Yeah. So by the time Arshia completes her feedback, anybody wants to ask or say something? So maybe for some of you, this could have been a very basic session. But the whole idea is that if we know that these are the skills that will be required in every situation, be it a situation which is very simple and easy to handle, or a situation where the patient is just out of control and very aggressive and violent, even there, these skills are going to be. And that's what is the idea, that if we know the basics. So the next session will be about how do you go about designing a program. As I said, that in the Master Trainer program, 2 sessions are devoted to how do you design a program and how do you facilitate a program. Because after all, if you want to be a trainer or if you want to understand training, you have to know what factors decide how the program becomes impactful. All of you must be doing training or teaching or coaching, but a lot of time it doesn't go well. So what are we missing in that? We'll be talking about that in the session 3. And session 4 will be more on the finer details of how do you facilitate a program. How do adults learn? So how do I make my program interesting for the adult audience? we'll be talking in session 4. So if I think Arshia is still doing. So once you're done, Arshia, just message that I'm done. Yeah. Sorry to have kept you.
I just wanted to say something. So maybe to answer Ashia's question at some point in time, right? My PhD topic is actually looking at understanding communication experiences of healthcare professionals, specifically to end-of-life care conversations, but this is in oncology and palliative care setups. What we've noticed over a period of time, I mean, at least me and my colleagues, is that especially end-of-life care conversations become extremely hard for all of us at some point in time, but there is no training, like we know. The trainings that we do are very generic, so it's a mixed group. So there are doctors, nurses, allied healthcare professionals, and we are not sure about what are the factors that are specifically contributing to Indian doctors or Indian oncologists, palliative care physicians, nurses, psychologists, as to what is it that confronts them when these conversations happen. So I'm looking at understanding perceptions and challenges, looking at what they feel as people, because most of the time we lose out on the human element of the physician or the medical professional. And the third thing is to identify gaps in training and in communication skills trainings that we have. So Asha, maybe in 4 years,
Yeah.
you might have some answers, which I hope I will get from the study.
So thank you so much, all of you. I know it's going to be 10:20. So next week, the challenge with me is that I'm traveling to Hyderabad for 3 days, which I was supposed to go this week. So I'm traveling on 19th and I come back on 22nd. So can we have this session on 18th instead of 19th? If it works for all of you. 18th will be Tuesday. Can we?
Okay.
Arshia, are you comfortable? Okay. Thank you so much. I'll just message in the group that next session will be on the 18th instead of 19th. Thank you so much. Bye-bye.
Thank you, ma'am.
Good
Thank you,
night.
ma'am. Good night.
Bye-bye.
Thank you.
Take care.
Good night.
Good night.
Good night, everyone.